care. So, to set the tone for this important discussion, I would now like to invite our esteemed chairperson, Dr. Manisha Wagh. She is consultant gynecologist, and Dr. Pushparaj Giri, Dr. Anand Joshi, and Dr. Girish Hiregaonkar, all are consultant intensivists. So, this session aims to highlight the multidisciplinary approach to manage critically ill obstetric patient, bringing the expertise of intensivist, obstetrician, and anesthesiologist together to look at real-life challenges and evidence-based practices. So, I will invite for the talk on seizures in peripartum period, Dr. Anand Nikhilje.
हां तसंच.
Thank you again, Team Nagpur, very strong team, very good organization. Thank for, I think my third, fourth time I'm coming here in this venue as a faculty. So this topic is quite practical and it's given to me like how to manage peripartum seizure. So when we deal with patients with pregnancy or peripartum period, it is usually, particularly seizure is quite rare. It is challenging to manage and there is no much data available for guidelines to make about seizure management in this patient, particularly category of patient. And when we treat expectorant or pregnant patient, we have to think of a baby also. So we are treating two patients at the same time. So when we talk about a seizure in peripartum period, we can categorize these seizures into three types. One is patients having pre-existing seizure disorder. So patient with epilepsy having a pregnancy or peripartum period. Then another category is new onset seizure due to non-pregnant related problems but can lead to seizures. They are metabolic alteration like hyponatremia, hypoglycemia, hyperglycemia, brain tumors, infections, viral or bacterial meningitis, sudden events or vascular malformation like we may get a stroke, IC bleed or cortical venous thrombosis. And most importantly, a pregnancy related condition that is most importantly eclampsia, which is a major cause of seizure in this category of patient, but also PRACE, ICH, cortical venous thrombosis, reversible vasoconstriction syndrome, TTP, and ARA or amniotic embolism can sometimes lead to seizure. So what seizure will cause to the mother? They will cause some obstetric complication like there is an increased risk of cesarean section, there is an induced labor, preterm births, gestational diabetes, patient will have preeclampsia, intrauterine growth retardation, abruptio placenta and stillbirth. And also these seizures will cause cell effect on the fetus, will cause hypoxia and lactic acidosis of mother which will transfer to the fetus by way of a placental transfer. And these tonic-clonic seizures are typically causes hypoxia and lactic acidosis, but other types of seizure also will cause fetal growth retardation, fetal injury and premature delivery. How do I manage? I am working in a tertiary care medical college, so whenever a pregnant patient comes to a casualty, there is quite a big scenario. And the management depends on where we see the patient first, whether it is in casualty, whether patient directly came to the ICU, or patient has a convulsion or seizure in the ward. So ultimately what lot of junior residents do, that they call all possible specialties, call to neurologist, call to obstetrician, call to physician, emergency physician, then do all possible tests, try to do a CT MRI when it is particularly not required, and give all possible treatments, and think of medical legal issue, particularly when you are dealing with a maternal critical care patient, and think of maternal mortality meeting afterwards. General consideration when we treat obstetric patient is, it is a unique challenge to the intensive, because the critically ill patient, actually there is a lot of anatomical and physiological changes occurs in the pregnant lady. The airway is difficult, there is an increased chance of aspiration, there is a reduced pulmonary reserve, hyperdynamic circulation will, with normal or lower blood pressure, there is a physiological anemia, drugs can cause some issues, there is a teratogenicity with the giving drugs to the mother, and there is a lot of hazards can, whatever intervention we do, like intubation, central line, and a lot of other intervention can cause problem to the mother as well as the fetus. And when we wanted to do some investigation like X-rays and scans and MRI, we should think of radiation hazards on the fetus too, particularly in early trimester. So if patient presents to the seizure, with the seizure to my ICU, first and foremost thing is take care of airway breathing circulation, as we do for a lot of other patients. Then take an IV access as early as possible, possibly 2 IV accesses, start oxygen, monitor and intravenous access, and then think whether patient requires intubation or not. If patient requires intubation, it is better to do a rapid sequence intubation in this patient and predict there is a difficult intubation in pregnant lady, particularly in peripartum period. And immediate seizure control is very, very important with some drugs like benzodiazepines. Then diagnose the cause of seizure, whether it is eclampsia or some other cause of seizure, relevant investigation, think whether you need to do a neuroimaging or not. You require sometimes a multidisciplinary team where you need an obstetrician, a physician, neurologist, and sometimes a neonatologist or pediatrician in a team. Then you have to think of appropriate time and mode of termination of pregnancy, postpartum care, care of a newborn, and then documentation of the whole intervention which you have done. Airway management, we know that in peripartum period is always difficult, and always prepare for a worst intubation scenario and call a person who is more experienced to do an intubation, particularly rapid intubation should be a standard of care when you are taking care of airway management. There is a algorithm by which we can treat a seizure in a peripartum period. So keep people around you, call for help, then check for the dangers, protect and clear the airway, give high oxygen, establish IV access, insert 2 16 gauge or 18 gauge cannulas, collect the blood for electrolytes, CBC, KFTs, LFTs, coagulopathies, and give anti-epileptic drug like benzodiazepines. Check blood glucose particularly in these patients. If you achieve intravenous access, give either lorazepam or midazolam to control the first episode of seizure. If you could not take IV access, then midazolam can be given intramuscularly. If you seizure persists after giving these primary drugs, and seizure remains for more than 5 minutes, then you have to give anti-epileptic drugs like levetiracetam or sodium valproate. If seizure is stopped within 5 minutes of the primary treatment, you can shift the patient to ICU and take a further call of neurology and manage post-seizure management of this patient. Even after your anticonvulsant drug, after 5 minutes, and your seizure is still continued, then probably you have to go for a rapid sequence intubation. You have to give some sedatives or anesthetic drugs in further to manage the seizure. And of course, remember that fetal monitoring, continuous fetal monitoring during this period is very, very important, particularly with CTG monitoring. Think if this seizure, whether it is status or not. Status epilepticus is defined as 5 minutes or more seizure activity or 2 recurrent seizures without return to the baseline. Status epilepticus is detrimental to mother as well as baby, which causes compromised placental blood flow, developmental delays, even death in this patient. And a pregnant patient can develop status epilepticus due to previously diagnosed epilepsy or acute neurological insults or trauma or eclampsia. Delay in starting treatment in status epilepticus, in particular pregnant, is very, very detrimental to the patient. So status epilepticus in pregnancy is life-threatening emergency for both mother and fetus, that we have to remember. If convulsive status, it can cause life-threatening complication to the mother, and the fetus will cause blunt trauma, hypoxia, decreased blood to the placenta leading to fetal distress. And the prompt treatment and address to the both mother and child, fetus, is very, very important. After urgent treatment of the convulsive fit, the next critical step is to diagnose the precise cause by which further treatment is actually decided. Sometimes you have to expedite the birth of fetus if there is a recurrent seizures or either a cytotomography is showing that fetal heart rate is varying. So algorithmic approach, as I mentioned previously, is very, very important in such situation. So immediate control of the seizure with taking care of airway, breathing, circulation, then control the seizure with benzodiazepines and then anti-epileptic drugs. Commonly used anti-epileptic drugs in this type of situation is phenytoin or fosphenytoin, sodium valproate, levetiracetam, lacosamide or topiramate. Any of the drug can be used in this situation. Remember, maximize the dose of anti-epileptic medication before adding to another drug. And you have to remember that loading dose is almost important even if your seizure is aborted with benzodiazepines. If in spite of your initial treatment, the seizure persistent, then it is called as resistant status epilepticus. And in this situation, you have to use IV anesthetic medication, including high-dose midazolam or IV propofol, IV barbiturate and ketamine. Sometimes because of this drug, you have to have invasive hemodynamic monitoring often needed to look for hemodynamic effects of these anesthetic drugs. Once you are control the seizure, you have to look for non-convulsive state, and you should have EEG monitoring in place in such situation in patients with resistant status epilepticus. Sometimes even after your intubation, ventilation and given anesthetic drug, the seizure is not controlled within 24 hours. It is called as super resistant status epilepticus, and it is a very difficult to manage these patients, and some experimental therapies can be offered like IV pyridoxine, ketogenic diet, induced hypothermia, electrical magnetic stimulation, steroid and immunotherapy. So seizure in pregnancy and or labor should be terminated as soon as possible to avoid maternal and fetal hypoxia. Alternative cause of seizure such as eclampsia, hypoglycemia, neuropsychiatric disorder should be considered always in this patient. You have to practice, or you should know how to resuscitate patient, pregnant patient. So you should have principles of resuscitation in practice. IV benzodiazepine is a drug of choice. So either you can give lorazepam, midazolam or diazepam. The advantage of midazolam that it can be given intramuscularly or buccally. Diazepam can be given upper rectally also if you don't have IV access. A persistent activity beyond 5 minutes, you have to give a load of levetiracetam 60 mg per kg, and maximum dose is 4,500 milligrams or infused over 15 minutes, or sodium valproate 40 mg per kg. If there is ongoing seizure activity 5 minutes post suggestion of IV infusion, proceed with rapid sequence intubation and transfer patient to intensive care unit. When seizure activity ceases, consider delivery of the fetus as early as possible. If there is a persistent seizure activity beyond 30 minutes, anesthesia with EEG monitoring is required, and maintain continuous cardiotopography monitoring for the fetal or uterine tone, and notify pediatric team if you are using benzodiazepines because it may cause neonatal withdrawal syndrome. Why these patients are getting seizures in pregnancy and peripartum period? Because of the stress, sleep deprivation, decreased adherence to anti-epileptic drugs. There's an increased hepatorenal clearance in peripartum period. There's an increased volume of distribution, change in protein binding of anti-epileptic drugs due to physiological hemodilution, and changes in hormones. So these are the causes by which seizures are quite common, particularly patients who are epileptic and become pregnant. What intranatal care we should give to the patient with seizure is adequate analgesia, because pain can actually stimulate the seizure. Pethidine in higher doses should be avoided or used with caution as it is epileptogenic. Epidural anesthesia is a good option. Less numbers of visitors should be allowed in the vicinity. Patient should be kept in a calm environment so that she can take sleep in between her labor pains. Bed dealing must be there, and one caregiver should be always present in the labor room along with the patient to keep a watch on the patient. Oral anti-epileptic drugs should not be discontinued. If patient cannot take orally, you should continue this parenterally. If patient is having high risk of seizure, then benzodiazepine can be used before patient gets seizure. Seizure in labor should be terminated as soon as possible with the benzodiazepine and then anti-epileptic drugs. Induction of labor. Most females with epilepsy have normal delivery. Seizure disorder in pregnancy is not indication of induction of labor. Hyperventilation and maternal exhaustion should be avoided as it can cause exacerbation of seizure in a laboring woman. Remember, epilepsy is not an indication of cesarean section but should be considered for obstetric reasons. Epidural anesthesia is preferred as it allows pain and prevents seizures. In case of repeated seizure or status epilepticus, consider mechanical ventilation and early termination of pregnancy. And as I told you, cardiac topography monitoring for uterine tonicity and heart rate of the fetus. Postpartum, remember, continue your anti-epileptic drugs, though the levels will rise in postpartum period, and there is a risk of anti-seizure medication toxicity. A neurologist or obstetric physician may monitor the anti-epileptic drug levels in a postpartum period. Provision of minimizing triggers should be considered, including good pain relief and support from the family and partner in a postpartum period. The most common cause of seizure disorder in peripartum period is eclampsia. I'm not going into details of eclampsia, but remember, it is a default diagnosis in pregnant woman or postpartum period that if patient gets seizure, always consider eclampsia as the first diagnosis. And in eclampsia, you don't have to do a CT MRI urgently. You can do CT MRI only when your convulsions are not typical of eclampsia, which actually aborts less than 1 minute, a tonic-clonic convulsion, or patient gets focal neurological signs and remains unconscious for long. In that particular kind of patient, you probably need neuroimaging. So don't push all patients of eclampsia with seizure for CT or MRI. Management of seizure in eclampsia is quite known to everybody. Magnesium sulfate is a drug of choice and it is well proven. Then you can treat the seizure with lorazepam, diazepam or midazolam. A dose of magnesium sulfate is also well known to the obstetricians and they are regularly practicing since last so many years. About 10% of the patients with eclampsia continue to have seizures despite magnesium administration, and in such cases you have to use either propofol or some anesthetic drug to avoid the seizure. There are some neurological condition. This is a well-known condition, that is a PRES, and there is no specific treatment. It usually comes with eclampsia, and you get a bilateral parieto-occipital shadows on the brain. It is a reversible condition and is a very common cause of seizures in peripartum period. And there are some other neurological condition, other condition which can lead to seizures. One is reversible cerebral vasoconstriction syndrome. It's a clinical radiological condition where patient may get headache and seizure with focal deficit. So we have to treat blood pressure if patient is having hypertension. Short-term epileptic drugs should be given. Then cerebral venous sinus thrombosis is particularly more commonly occur in peripartum period, and you need to diagnose it with MRI brain with MRI venography. Patient may present with the seizure and headache and disturbance in the consciousness. Heparin is the drug of choice. Remember, heparin therapy can be restarted after 6 hours of the vaginal delivery and after 12 hours of the cesarean section. So treatment with heparin is very, very important in cortical venous sinus thrombosis, and of course anti-epileptic drug has to be given. TTP sometimes can cause headache, seizures, and you know the treatment of TTP like plasma exchange, platelet transfusion, steroid, rituximab. Amniotic fluid embolism sometimes can cause seizures. It is a very dreaded, unpreventable complication of delivery, and multidisciplinary approach is required. So at last, what I wanted to tell you that if there is a doubt whether seizure is secondary to epilepsy or eclampsia, give magnesium sulfate, which is a drug of choice for the treatment of eclamptic seizure and should be administered until you clear your diagnosis. Plan delivery where facilities to take care of mother and neonate and a critical care backup should be actually we should plan the delivery in such setup where treatment facilities are available. Multidisciplinary team approach is very important, and mode of the delivery should be dictated by obstetric indication, not by Caesar per se. Benzodiazepine followed by anti-inflammatory drug and sometimes rapid sequence intubation and anesthetic drug is a key to manage, like in all adult patients of status epilepticus we manage. Support mother and reduce triggers which will cause seizures to the patient or pregnant woman. Thank you.
Thank you, sir, for the excellent and comprehensive talk. I would like to invite Dr. Sudhir Chafle, sir, to felicitate Dr. Anand. Moving to our next talk, approach to acute breathlessness in pregnancy, I would like to invite Dr. Kapil Borawake. He is consultant intensivist at Prayag Hospital and has delivered multiple talks in multiple national and international conferences and has multiple publications. We will
Yeah.
take questions at the end of the session.
Yeah, good afternoon and thank you very much, Team Nagpur, for giving this opportunity. With respected chair, in next 15-20 minutes, I'll try to touch upon what are the differences of breathlessness in pregnancy. If you look at a pregnant patient, more than one-third of them, they will have reported dyspnea in some time of their ANC period. But not all the dyspneas what we encountered are pathological dyspneas. Many a times that can be a physiological dyspnea because shortness of breath is very common complaint by pregnant females. But the survey what has been done during COVID time, it is clearly mentioned that you should not ever neglect this dyspnea. Now, before understanding why pregnant patients are different, you have to understand what are the difference it makes that pregnancy is making into our cardiovascular system and respiratory system. So what it does, it is increasing blood volume and cardiac output. It is decreasing systemic vascular resistance. They will all be tachycardic. There might be a flow murmurs and that can sometimes mimics heart failure also. And you have to be aware of this. Secondly, what changes it made to the respiratory pathology, that is there will be increase in the tidal volume, leading to increase in the minute ventilation, and this is very important. It leads to decreased functional residual capacity to the tune of 20%. Due to progesterone, there will be increased respiratory drive. So normally, if you look at their ABG, they will have metabolic alkalosis. And this physiological dyspnea usually is non-progressive. Now, if you look at what happens to diaphragm, if diaphragm will be having a rise in at around 4 to 5 centimeters, and this sometimes gives something like a pre-stretch effects that can lead to increased contractility also. Now, these permissive changes, actually what it leads to, the ribs will be flared outwards as relaxin increases and the angle with Jeffrey sternum flattens, and these changes can also lead to probably altered mechanics in breathing in females. And particularly those who are having multiple pregnancies and polyhydramnios, this diaphragmatic splinting can also play a part in their dyspnea. So this is a chart just to summarize how much difference it makes as the time passes by. So to the term, their functional residual capacity is significantly reduced. So to just summarize what physiological changes we have in blood volume, cardiac output, elevation in diaphragm, decreased FRC, stable FEV1, increased ventilation, respiratory drive, and respiratory alkalosis with increased arterial O2 tension. Along with that, it is going to increase plasma volume by 45%, and at down you can see this is a procoagulant state. So this prothrombotic state has to be considered when you are dealing with any dyspneic pregnant females. So what differentials we should keep in mind? The most common differentials, if you divide system-wise, the respiratory are acute exacerbation of asthma, PE, amniotic fluid embolism, ARDS, cardiac like pericardium cardiomyopathies, valvular lesions, severe anemia, which is very common in our part, metabolic acidosis due to decay, sepsis, and never ever forget anaphylaxis. So what are the red flag signs when you see these patients? If your patient's respiratory rate is more than 30, if your saturation is less than 94, you have to be a bit more vigilant because here fetal hypoxia is also important. So we talk about sometimes permissive hypoxia, but never in pregnant females because we have to take thinking about baby also. So anybody who is developing orthopnea, cyanosis with chest pain and hemoptysis should be considered a red flag signs. And abnormal auscultation and new murmur needs probably more attention and immediate transfer to ICU, which most of our gynecologist colleagues they don't want. They want us to treat them in the ward. So differentiating between physiological and pathological dyspnea, it all depends upon the onset, how they have progressed, associated symptoms, and what position your patient's dyspnea is worsening. Suppose your patient is not able to walk few steps, definitely is a red sign, and physical examination findings will favor your pathological dyspneas. So if you plot the key causes and the key symptoms, history becomes very important in these patients. You have to think about pulmonary embolism when there is a pleuritic chest pain, which is a sharp pain, anemia particularly, any history of blood loss, previous transfusions, cardiomyopathy if there is previous history of cardiomyopathy. So if you plot a graph and see how many of patients who had undergone so many ultrasonographies in their ANC, we hardly find any echocardiography done to them. So we always probably press on to our gynecology colleague in their ANC once their echocardiography or echo should be done to understand how walls are there, how muscle is functioning or not. Then pulmonary edema can be a contributing factor to multiple, like it can be fluid overload, it can be correction of anemia, it can be valvular heart disease which has probably progressed. And infections are again common. Asthma, I'll talk about a brief. New onset asthma is rare, but whatever asthma is there that can aggravate. Again, pulmonary hypertension, pre-existing pulmonary hypertension, if PA pressures are very high, is an absolute contraindication to pregnancy. But if there is mild pulmonary hypertension, then probably you have to look at the pre-existing conditions. So our diagnostic approach doesn't change much in any other dyspneic patients, like you should have an initial clinical assessment, basic investigations, you should have a severity assessment and stratification, and again multidisciplinary approach has been probably at the beginning of this thematic session we talked about multidisciplinary approach, intensivist with cardiology, pulmonologist and gynecologist working together. Investigations, ABG, ECG, echo, very, very important. Now we are very reluctant to do the chest x-rays, but I think I'll show in my slides why this is important. Because when you have to save a mother, you have to first think about a mother. And for saving her, if you require investigation, that should not be delayed for the sake of radiation effects. Then D-dimer and pro-BNP, that will help, and CTPA and VQ studies if required. So again, just to summarize this, you have to look for the red flag signs. If your red flag signs associated with symptoms, like suppose there's an orthopnea and PND, that is likely pointing towards the cardiac causes, then you have to think about valvular pathology or cardiomyopathies, or never ever forget that these patients can still have ischemic heart disease. If there is a fever and cough, think about infections, and in asthma, previous history is important. And if there is a chest pain and your cardiac disease has been ruled out, there is a likelihood of spontaneous pneumothorax or pneumomediastinum or pulmonary embolism. So functional approach history taking is very, very important. And again, key part here is nocturnal symptoms are very, very, very important. Somebody who is become dyspneic in the night should alert us to have more aggressive evaluation of these patients rather than waiting for them to come to the casualty with emergencies. So women who had no cardiac history, when they come first time in pregnancy, there will be rapid increase in the circulating volume. So what happens, there is a pre-existing heart disease, but it is quiet. Once the stroke volume is increasing, circulating blood volume is increasing, that will lead to increased cardiac output, and our cardiac capacity will not be able to handle that increased cardiac output, and that can lead to cardiomyopathy. But pericardium cardiomyopathy usually at around 36 weeks. So early cardiomyopathy is very unlikely. Again, key important points are avoid ACE inhibitors, and newer therapies for heart failure because they're absolutely contraindicated. Avoid SGLT2 inhibitors. The study or data in pregnancy is absolutely not there. You can use diuretics and digoxin with caution. Next is thromboembolism. Again, pickup rate for thromboembolism. If you have a high index of suspicion, you go for lower limb Dopplers. If there is an absence of DVT, if your D dimers are high, pro-BNP is high, then go for CTPA and try to diagnose them as early as possible because CTPA is the gold standard for diagnosing pulmonary embolism. And why it is important because once your D dimers are high, 1.5 times of normal, and if you probably diagnose them in time, you can treat them adequately. So look at this slide which talks about how much is the radiation one chest X-ray or one CTPA will have. Normally the radiation which is hazardous to fetus is around 50 m gyrus. So here the amount of exposure is very, very less. So all the radiology papers are saying that there is no need of shielding because that may hamper your diagnostic capacity of that X-rays or that CTPA. So you can boldly do imaging studies in these patients. Management doesn't differ much in pregnancy except you should never use DOACs. You should use heparin, either low molecular heparin. If you are planning a cesarean section, then probably you can stop LMWH a day prior, start on heparin. And as already told by Anand sir, you can start heparin 6 hours prior after normal delivery and 12 hours after heparin. So we are doing thrombectomy in these patients where anticoagulation is contraindicated. Again, anemia should always be considered in your diagnosis, and first line should be replace, give Paxil volume or correction of iron. Then coming to preeclampsia, how it leads? It leads to endothelial dysfunction, vasospasm, increased capillary permeability, and decreased oncotic pressure, leading to pulmonary edema due to fluid overload and vascular leakiness and increased systemic vascular resistance. Again, controlling blood pressure here is very, very important. So sometimes we can have a dual pathology. So we have to consider diagnosis of, again, echo is very, very important and CTP also important part. Key is early imaging. Cough is very common symptom, but make sure that cough may be due to progesterone-induced airway edema that can lead to nasal blockade, rhinitis, cough sensation, particularly in viral infection. It's very, very common. Again, that can not lead to a severity, but you should be aware about this. And pneumonia is the most common diagnosis what with patient comes to ICU, particularly due to bacterial pneumonias. Here, early antibiotic therapy again is the key, and you have to de-escalate as early as possible. Non-infective causes to start with, it can be GARD also, leading to around 50% pregnancies. They can have chronic cough. They will improve with PPI, and because that is also a risk factor for aspiration. Another important factor is asthma. Here, if your patient is having V's and who just already have pre-existing asthma, then you should have a proper history of your asthma control and any past ICU admissions. Usually 2/3 of them do well, but 1/3 they will worsen, and they are linked to preterm birth, small gestational age, and preeclampsia. Important here is the drugs are safe in pregnancy are steroids, oral prednisolone, beta agonist. Again, adherence to therapy is very, very important. So if you can plot asthma when they come to ICU, who are pregnant, usually they come from 17 weeks to 24 weeks of gestation. So if somebody is asthmatic, you have to be very sure that you have to take care of them during this 8 or 10 weeks time and have a better bronchodilator therapy to avoid. And if all of your therapies fail, then you can use IV magnesium sulfate in this patient. Even you can use terbutaline also. Chest pain, again, it can be due to respiratory causes and cardiovascular causes. We had never ever think that ischemic pain will not be there in these pregnant patients. There are other possibilities because costochondritis is very, very unlikely in these patients. So never to forget aortic dissections and pericarditis in these patients. So just to brief, if you have to evaluate, look at the history and physical examination. Look whether your dyspnea is acute or gradual onset. Again, pulmonary embolism is usually associated with sudden onset dyspnea, and spontaneous pneumothorax should never be taken out of the question. Again, risk factors, smoking. Be bold enough to ask history of smoking to pregnant females because the amount of smoking is increased over last 1 decade. Then look for airway obstructions. Many a times, patient will be at some other hospital coming to with acute dyspnea. There may be the possibility of anaphylaxis that should never be kept out of the box, and acute cardiac tamponade should be considered. And cardiac tamponade, again, you have to have a triad where there will be chest pain, tachypnea, and worsening dyspnea. This can be life-threatening also. So bedside echo here is very, very important because JVP will be elevated, but there is very limitation when we talk about JVP. But definitely bedside echo is very important. And listening for these patients for wheeze is also important because that will definitely try to rule out respiratory causes from the cardiovascular causes in these patients. So if your patient's chest is clear, probably you will think about PE and other aspects. And if you are showing a signs of heart failure, probably the wheeze can be there in asthma patient and crackles can be there, particularly when lung parenchyma is involved in left ventricular failure. So basic clinical examination not to forget. So you have to understand at what term of pregnancy your patient has come, which already have shown that towards term, at the end, pericardium cardiomyopathy, in between 17 to 24 weeks, asthma, and beyond all the time because it's hypercoagulable state, pulmonary embolism should be considered. And non-specific fatigue, chest discomfort, or abdominal pain may be an initial evaluation due to occurrence of similar symptoms in pregnancy, but repeated examination is very, very important in these patients. So never hesitate to do chest x-rays and not to forget D-dimer and ProBNP in these patients to rule out cardiac from respiratory causes. Thank you very much for patient listening.
Thank you, sir, for your sharing your valuable clinical insights.
I would like to invite Dr. Ashish Gandre sir to felicitate Dr. Kapil Barak. Next we have Dr. Yatindra Dubey speaking on approach to coagulopathy in pregnancy. Dr. Yatindra Dubey is concerned physician and diabetologist from Nashik.
Thank you very much. Thanks, Deepak. Thanks, Mark Reticon 25. 28 years female patient, 2 months pregnancy, third gravida. She had a bleeding PV for 8 days. She underwent MTP. She has a excessive PV bleeding post-procedure. She received PCV and she was discharged. She went to her Maher. After 3 days, she had a sudden collapse at home. She was shifted to the hospital. Hemoglobin 5 and the platelets were normal. She received PCV. She was on vasopressors, she was on oxygen, and she was in a state of shock, and she was shifted. When we saw, then she was conscious, heart rate 104, BP 104/60 on NORAD, no TGR, the systemic examination was normal. She was pale. On labs wise, platelets was 29,000, LFTs were deranged, prothrombin time was normal, PT-PT2 was normal, procal more than 100, creatinine 7.1 out of proportion. Urine output was 30 cc per hour, LDH was high. If you look at the reports, platelets are down, PT-PT2 is normal, creatinine is out of proportion, and LDH 1980. USG abdomen was normal, and we took a gynec consult also, and as per gynec consult, there was no fresh bleeding. So issues were post-MTP bleed, shock, multiple organ failure. The odd point was AKY was out of proportion. Coagulopathy looked like a DIC, very likely consumptive or maybe secondary to sepsis. Septic shock was possibility because procal was very high and the clinical setting was that. Whether it was a microangiopathy, this is the second trimester. TTP, HUS were the differentials because creatinine was out of proportion. We went back to the history. She had a bleeding during, excessive bleeding during dental extraction. She used to have menorrhagia, but there was no positive family history. So we did keep in mind whether she has a disorder of coagulation. Now, DIC, look at all the differential. DIC possible, fibrinogen was sent. We don't have a TEG and ROTEM. Now the question was to give FFP, cryoprecipitate or fibrinogen. If you look at the hemoglobin was 10, dropped to 3, and she received transfusion, and still the platelets were low. So possibly she has DIC. FDP came more than 40, and D-dimer was high. So she had DIC. Septic shock, ProCal was high, MTP and WBC count high. So septic shock. But again, creatinine was out of proportion to everything. Microangiopathy was a possible, but usually microangiopathy we see TTP-HUS in the third trimester. So that was the odd point. There was no significant post family history. We did a peripheral smear, so cystocyte was just 0.3%. Retic count was 1%, haptoglobin was normal. So microangiopathy was there in the mind, especially with the creatinine was so high, but possibility was much, much less. Is it maternal coagulation disorder? We did keep in mind, but looking at the scenarios and the overall the picture of lab findings, this was a less likely. She was managed, she was treated with the antibiotics, she was treated conservative initially, platelet improved, but creatinine went up to 8.5, and she was dialyzed yesterday, and today I am told when I left, she is better. So coagulopathy in pregnancy is, again, we know it's a combination of the factors. There is a procoagulant activity because during pregnancy factor 8 and 7 and 10 and 11, 10 and fibrinogen becomes high. At the same time, fibrinolytic activity goes down, so pregnancy is a hypercoagulable state. The coagulopathy presentation in our clinical practice can be sudden, can be unprecedented, and can be catastrophic. So what we need is a vigilance and anticipation. Now let's come to the DIC. DIC is the leading cause of maternal mortality. It is secondary to some precipitating cause or some other cause. It's extraplacental dissemination of the activated coagulation system. It's basically endothelial dysfunction with microvascular deposition. Now these are the causes of DIC in pregnancy. Now this is a study which has shown that still the commonest cause is abruptio placenta, postpartum hemorrhage, preeclampsia, and sepsis. So these are the commonest cause of DIC during pregnancy. Now the diagnosis of DIC, how will you diagnose DIC in pregnancy? It's a clinical, basically a setting in which the patient is there and where you anticipate this patient can go into DIC. Then the lab-wise PT, APTT, platelets, fibrinogen, FDP, and D-dimer. Now there is something called DIC score. And when you look at the DIC score, the one score which is really a bit of validation in the pregnancy, where the platelet count, fibrinogen, and the PT difference between patient and the control when the it is more than 26, the possibility is more than 80% of having DIC. Now this is a DIC score. Now point of care test is a TEG and ROTEM, where you can pick up fibrinogen deficiency and the early DIC early. And in fact, you can predict about giving the product of cryo and the FFP early based on the FIB-10 score. Less than 12, less than 7, they will require. More than 15, they will not require. Now the treatment is basically the treatment of the cause, and the treatment, what exactly is the precipitating cause, and secondly is giving the blood and blood product management, ICU management, and the hemodynamic monitoring. So you have to activate the massive transfusion protocol. You have to give FFP, cryoprecipitate, fibrinogen. It's a dynamic process. The goals are to keep fibrinogen more than 100 milligram per ml, platelets more than 50,000, PT and APTT normal. Heparin is still a controversial. Only the two indication in pregnancy is going to amniotic fluid embolism or intrauterine fetal death with DIC. Factor 7A has been described. So this is about the DIC. Now let me come to thrombotic microangiopathy. Now the four conditions which can come with us of the thrombotic, the thrombocytopenia, TTP, HUS, HELLP syndrome, and eclampsia, and the TMA associated with antiphospholipid antibodies. Now the clinical presentation is going to be during the term, or immediately post-term. Patient is come to us with history of fever, thrombocytopenia in the state of shock, or they may have a neurological symptom and they may have a renal failure. One of the features is going to be anemia, which may be mild in case of TTP and which can be very high in the HUS. LDH is high. There is going to be decreased heptoglobin. Smear is going to show the cystocytes. And there is one condition of renal limited TMA where you will find features of hemolysis will not be there, but renal failure will be dominant. Now, how will you differentiate between TTP versus other thing? Here, the platelet count is going to be profoundly low, maybe around less than 30,000. Renal failure will be relatively less, and there is something called the plasmic score, which is going to help us. Again, it is because of ADAM-TS antibody deficiency, which can be acquired or which may be congenital, so we have to send the investigation. All this investigation take time, so you have to start plasmapheresis pending investigation. Start immediately. Now, treatment is again plaque, steroid, rituximab, and one more drug is a caplacizumab. Now, health syndrome we all deal in the day-to-day practice. Now, the criteria is going to be BP more than 160 by 110, with one of the finding where the platelet is less than 1 lakh, deranged LFT, patient has symptoms of right upper quadrant pain, blurring of vision, or pulmonary edema. Treatment is delivery. Thrombotic microangiopathy, HUS, one of the criteria while I was preparing for the talk is the LDH more than 1800 and the creatinine more than 1.9 associated with hemolysis. Think of complement mediated thrombotic microangiopathy. All you need to send a genetic study, and please remember the treatment is going to be early plasma exchange, steroids if the antibody is positive, and eculizumab. In fact, I had one patient we used eculizumab, the results were very good. Apla syndrome again associated with TMA. There is again going the history of early pregnancy abortions, and they may come with the multiple organ dysfunction. A few subset of the patient may come up with a catastrophic Apla syndrome, where they may have a thrombotic episode, strokes, and multiple organ dysfunction. Treatment is again plasma exchange, IV, IgG, steroids. Now this is schema of the diagram. Acute coagulopathy in pregnancy, again, history of bleeding in the past, positive family history. If those history is there, you are going to suspect this condition. Still, the three common conditions is the von Willebrand syndrome, hemophilia A, and hemophilia B. Diagnosis is by the clinical history, and you need to have a hematology consult for that. I'll take you to another case, 24-year-old female patient. She had a mild PIH. Because of non-progression of the liver, she went cesarean section. She did well for 3 days, and after 3 days, when she was mobilized, she collapsed. Initially, it was thought the vasovagal. She was shifted to bed, fluids were given, she was resuscitated, but still saturation was low. There is no history of chest pain, palpitation, no history of similar episode in past, no abortion in the past, no history of diabetes. Heart rate was 190, BP systolic. She was conscious but drowsy. Systemic examination was normal, and she has a post-LSCS maternal collapse after 3 days. The differential was whether she has pulmonary thromboembolism, or whether she bled, or whether she had any peripartum cardiomyopathy. Now, this was the ECG what she came with. She has a severe sinus tachycardia. Lab-wise, hemoglobin was 7.5, but creatinine was 2.5. SGOT, SGPT was high. D-dimer was more than 10,000. NT-BNP was 407. Troponins were high. And ABG-wise, she had a bicarb of 18.5 and lactates were high. 2D echo showed RA-RV dilated, and she has a severe PH. But if you look at the entire clinical scenario, her X-ray chest was normal. She was initially put on NIV, vasopressor, supportive line of treatment. CT pulmonary angio done immediately, which was showing a thrombus in the main pulmonary artery. So at this point of time, she has undergone cesarean section. Within 3 days, she developed the pulmonary thromboembolism. What are you going to do? The best option was doing the catheter-directed thrombolysis, but expertise and the cost. I think cost was the major issue, so that was deferred. Thrombolysis was a possible, but the chances of bleed was very high, expectation was very high, so risk was there. We had a cardiac consult, gynec consult, sonography abdomen did not show any evidence of bleed. So these were the options what we have. So the thing was that we have to choose one option because patient has severe pulmonary thromboembolism. She was thrombolized initially with 50 milligram of Actylis. As you remember, there was one trial of half dose of thrombolysis, but that trial was in the intermediate group. She was on NORAD support. BP dropped. Her heart rate improved 180 to 140. Electrics improved. In fact, she started improving in first 24 hours hemodynamically. Next morning, she had a bleed. She had an abdominal wall hematoma. Again, she was treated with the supportive line of treatment. However, over next 5 to 7 days, she improved. She was clinically fine and she improved totally, and your PA pressure and the RV dilation improved. Now, the risk factor for this is, again, I said, history of any thrombotic DVT in the past, DVT in the earlier pregnancy, or the positive family history. Other risk factor, if you look at, LSCS itself is a risk factor, eclampsia itself is a risk factor, PPH itself is a risk factor for developing that. Diagnosis-wise, we know everything, VQ scan, CT pulmonary angio, and ultrasound, and D-dimer has a very poor sensitivity in the terminal stages. All the severity score which has been described in the non-pregnant women has not been validated. So these are the score which has been described. So thrombolysis in the pregnancy, this was the article what we, before thrombolizing, we discussed, we had a discussion amongst ourselves. 1 out of 3 in immediately post peripartum period with the risk of bleeding, still 1 out of 3 will receive thrombolysis. In spite of the thrombolysis, risk of bleeding is less, and the maternal survival is good in spite of their bleeding. In fact, 94% maternal and 88% fetal survival. Risk of bleeding is 18% during pregnancy and 58% post-partum. Options I already discussed, but one more option when I was preparing for the talk is you breathe them with the ECMO and do that. Just last one slide. Pregnancy and DVT in ICU is again, it's a more of a left side, it's a more of a larger vein, and what you need is the investigation. So in summary, coagulopathy in pregnancy can be sudden, unprecedented, and catastrophic. Awareness of pathophysiology and anticipation of coagulopathy helps in overall outcome. Distribution of healthcare system between privileged and unprivileged is a big issue, like second case where we have to thrombolize in spite of knowing that this is going to be going to have a problems. But in spite of all the problem, it's still the most rewarding medical emergency. Thank you very much.
Thank you, sir, for that comprehensive and insightful presentation. I invite Dr. Kaustubh Upadhyay to felicitate Dr. Yatindra Dubey.
I would like to invite our next speaker, Dr. Shalmili Sinha, for talk on acute liver failure in pregnancy. Dr. Sinha is Senior Consultant Critical Care Medicine at Apollo Hospital, Bhubaneswar. She has more than 18 years of experience in critical care and is at invited faculty at many international forums. She had more than 30 publications and is recipient of multiple ISCCM Presidential Award. Over to you.
Thank you for your kind words of introductions, and thanks Team Nagpur for this kind invitee. I remember when I was city registered in Mumbai, I always wanted to come to Nagpur because I had many friends who belonged to the city, and finally I'm here. And since beginning of the sessions that we understand why this obstetric care is being discussed, maternal mortality rate is one of the still concerns at nationally and globally. Though India has done tremendously well in the last decade, and our MMR has been brought down from 118 to 88 national average, there are around 6 states which still MMR is quite high. And I think this is the way forward, that we continue to propagate the knowledge and training and raise awareness about how maternal mortality and morbidity could be brought down. Thanks to my previous speakers, they have thrown light on the physiological changes associated with pregnancy. And one of the last topic of the day is about approach to acute liver failure in pregnancy. So these are the learning objective of this session. Hepatic dysfunction in pregnancy can happen. However, we'll be talking mostly about the common causes of acute liver failure, which happens in pregnancy, how we approach diagnosis, management, and the key points. So, as we understand, among all systems which undergo changes during pregnancy due to physiological alterations, deranged liver functions can happen and affects up to only 1 to 3% of all pregnancies. Having said that, even though this percentage is less, actually the related mortality and morbidity is high if it's not gets proper attention, and if one lands up in acute liver failure, then mortality disproportionately rises. You heard my previous speaker, Dr. Yatindra, talking about coagulopathic changes, and one of the major causes of coagulopathy leading to high morbidity and mortality are related to hepatic dysfunctions. So these are the few changes which happens in pregnancy. About, if you look at the enzymes, alkaline phosphatase rises 3 to 4 folds. However, other transaminases do not rise much. Clotting factors all rises, so it's a hypercoagulable state. And there is decreased gallbladder contractility. Albumin and protein levels are largely reduces due to hemodilutions. And there are no changes in the bilirubin level or the prothrombin level. Important to note is about the prothrombin. There's no point. Actually, prothrombin time rise in the PT time is actually one of the earliest indicators of impeding liver failure in such cases. That's why that is the importance of documenting PT times. So this is the kind of a summary table. This is found in most of this textbook or the literature you find it. These are largely divided into 3 categories: pre-existing liver diseases which could be coincidental with pregnancy and manifesting, and which are unique to pregnancy. So mostly those are this acute fatty liver of pregnancy, severe preeclampsia, eclampsia, then you have the HELLP syndrome, you have discussed it, intrahepatic cholestasis of pregnancy, and hyperemesis gravidarum. Hyperemesis gravidarum usually happens in the first trimester of pregnancy, and very rarely it leads to acute liver failure, so we are not much worried about that. But other 4 conditions which are in the liver unique to pregnancy are the causes of concerns, and of these, which are mostly sometimes overlapping or creates a clinical dilemma, patients who present with sepsis and septic shock with multi-organ dysfunctions, that could be an element of HUS, hemolytic uremic syndrome, which may not be distinctly present as a diagnosis, is one of the cases you heard Dr. Dubey was presenting. Mostly of these pathoetiologies, they have overlapping presentations. However, the beauty of it is, it doesn't matter, you do not have to pinpoint a diagnosis, you have to initiate the right resuscitative care at the right time, take multidisciplinary approach, and early referral to a higher center. These are 3 key components which helps to reduce and save both the mother's and the fetus's life. And among the unique etiologies which are relevant to our subcontinent are the tropical fevers. Do not ignore these tropical fevers, because malaria, dengue, and scrub typhus continues to be the high causes of all infective presentations that end up landing in critical care units. And also drugs are to be blamed. We had a panel discussion on the toxicology, and do not forget about these NSAIDs, like mostly the nimesulide and this non-steroidal anti-inflammatory agents, which are very easily being abused in our community. And one of the causes of disproportionate finding of renal failure, probably which case was being discussed, could be administration of this non-steroidal anti-inflammatory drugs. I still see the very fair and free prescription of these NSAIDs drugs in the post-op patients also for pain relief. Now we have many safer agents available, but still for some reasons these are very popular and are a major contribution for causing AKI of various degrees. So this is again a chart which summarizes the pregnancy specific or unique cases, and of this I'll just talk about more about this eclampsia and preeclampsia. I think we know the features, we are not going into the details of it, and usually this manifests in the 2nd or the 3rd trimester. And uric acid level is elevated, ALT will be high, and proteinuria is present in all of these cases, because by definitions preeclampsia or eclampsia, they have high blood pressure along with a protein stick positive for proteinuria. HELLP syndrome, we know that along with hemolysis, low platelets, and elevated liver enzymes are there. And AFLP is one of the acute conditions we'll discuss in the next slides. These are the similar ones which actually kind of describes more of the lab features and the gestational age, etc. I would draw your attention to that HELP syndrome is actually one of the variants of severe preeclampsia. So most 80% of cases of HELP would have associated high blood pressure. So blood pressure is high in such cases, and similarly in severe preeclampsia and eclampsia, of course, the diagnostic criteria includes it. In contrast, in acute fatty liver of pregnancy, the blood pressure is usually normal or low because patients who have got predominant liver pathology, they have a vasodilated state. So systolic and even the diastolic blood pressure is on the lower side. These are the two differential diagnostic features between AFLP and severe preeclampsia or the HELP syndromes. So general approach, the ABC of resuscitation applies to all of these patients. Whatever said and done, whatever differential diagnosis you have in mind, you have to initiate timely resuscitation for these patients and take good history, as he said, as well has been discussed already, because in our places, actually, there is a segment of populations who have got this underlying blood disorders, mainly the sickle cell anemia. So they might have this underlying hemolysis started, and they would not know till that point of pregnancy, second trimester or the early third trimester, when they have this crisis, and they kind of tolerate pain. Pain tolerance is very high in pregnant, especially in the lower socioeconomic status. And if you just do a blood smear or sickling test in these patients, you know about this underlying sickling trait, which will probably getting decompensated. So good clinical examinations, the basic blood test that we usually send for these cases, and need to definitely exclude the tropical fever. Sepsis is a high possibility. Serum uric acid is not available, I understand, in all places, and it may not be the, something which comes to a mind at the outset. But having said that, if you are suspecting a preeclampsia or other kind of hemolytic disease, etc., or the rarer causes, do send for uric acid, probably at the later stage. Hepatitis A and E continues to be common, though hepatitis E is more commonly associated with pregnancy than other varieties of hepatitis. And among imaging, ultrasound is very much useful, can be done with minimum radiological exposure, and CT scans are very rarely necessary in patients mostly for evaluation of jaundice. And also go for a routine microscopic examinations along with a dipstick, because it gives you idea about this microalbuminuria. So these are the two cases actually I have, just to summarize what I have already discussed. This is a 22-year-old primary gravida. She was already known to have twin pregnancy. Now, BP was normal throughout the antenatal checkup period, no hematological disease diagnosed. Just before delivery, she was diagnosed to have yellowish sclera, and then she was taken for LACS, delivered a twin baby. Thereafter, she had a bout of PPH, peripartum hemorrhage, which was managed with transfusions and tamponade. But after that, she continued to remain hypotensive. She was put on oxygen with IV fluids. She was shifted to us. On arrival, she was tachypneic, hypotensive, and tachycardic. Now, so what are the differential diagnoses? How do you think we can manage her? And how should we investigate her? The basic investigations were sent, which showed actually deranged liver functions. She went into respiratory failure. There was metabolic acidosis and acute kidney injuries. Ultrasound was done, which showed a large uterus with some, artifacts were there. There were moderate degree of ascites also present. So these are the 4 differential diagnoses which come to our mind just immediately after delivery by cesarean section, with jaundice and hypotension and shock state. Peripheral sepsis or AFLP or severe preeclampsia or viral hepatitis. Anyone? Anything? What is more likely? I mean, that's nothing right and wrong. Preeclampsia, yes. Anything? AFLP, yes. Puerperal sepsis, not possible? Yes. I think, there is nothing right and wrong, because all these are the 4 things which comes to our mind. Nevertheless, the general management remains same. So these are the blood tests. Total bilirubin is very high, to the tune of around, and this is a matter of 1 week. She became yellow maybe 3 to 4 days before delivered, and next day she deteriorated. So within 4 to 5 days, this has manifested. But see, the bilirubin has gone up to 12 mg/%, which is quite high, and direct is higher than the indirect one. AST, ALT are also elevated. Creatinine is also high, not very high, and she was oliguric initially, and after resuscitation, she started pouring good amount of urine. TNC was to the tune of 35,000. So probability of puerperal sepsis is also quite high in our communities, because there could be some degree of chorioamnitis, mild of the leaks, infections, patient just tolerate it because, they say 8 months, 9 months, they want the baby to mature and deliver. So it depends on their threshold of tolerance and presentation to the healthcare center. So these are the few other additional invest findings. So TNC gradually decreased with antibiotic management, platelet counts kind of remained steady and then improved. And uric acid was very high. What would be the significance of uric acid? 11.2. D-dimer was not so high. So the point we want to make is, and you can see the reticulocyte counts. It also remained kind of little high, went up and then stabilized. So there is a multitude of etiology here. And to your surprise, lately on the day 5th of admission, we found this hepatitis E IgM antibody was strongly positive. It was strongly positive. So it was probably, there was viral hepatitis was there. It precipitated sepsis, but maybe chorioamnitis, UTI, you do not know. She presented to us with AKI, DIC, and with just conservative management, she improved. She did not require dialysis. She did not require ventilations. So that is the beauty of this obstetric cases. As we have seen that these patients, if there is timely management, resuscitation is done. For that matter, you do not have to pinpoint a diagnosis. Actually, survival rate is very good. And if it is beyond second trimester, nowadays the fetal survival is also good. So early referral, take consultations from the nearest referral hospital by tele-ICU facilities. These are the two things I think which in the digital era can help saving these patients. So this is the second and the last case. 28-year-old lady, 30 weeks pregnancy at village. ANC check was irregular. Now 2 weeks before, she was diagnosed of high blood pressure and started on some medicine. Most likely, preeclampsia was there. The one day she had pain abdomen, water leak, she was taken to a local district hospital and CS was performed for fetal distress. Baby could not survive. Now post-op after 8 hours, she was found to have jaundice, bleeding with PPH, and she was given some pack in situ and while she sipped with oxygen. She became drowsy, hypotensive and shocked and deeply jaundiced with low urine output. Now these are the lab findings. You can see severely deranged liver functions, creatinine is high, and deranged coagulation. So what are the differential diagnoses? These are the almost 5 I have written. What is more likely in this case? Post-op, severe deranged liver functions with all multi-organ dysfunctions, counts are high, low platelets, and she is already just diagnosed to have preeclampsia in the before delivery. Anything is possible, right? She was intubated, ventilated, we dialyzed, we gave all this blood products along with some factor concentrator also, but there was rapid production of organ failure and she succumbed. Most likely the acute liver failure of pregnancy, it has got a disproportionate rise of liver functions compared to all 5 etiologies which I have put as a diagnosis. These are the patients who actually, if anything, it is unique to pregnancy, usually it improves after delivery of the fetus. But AFLP is a diagnosis, actually is the etiology, which tends to, once it has come to a stage of decompensation, they tend to rapidly decompensate and usually mortality is very high to the tune of 80%. In the last 2 weeks, actually, we had two obstetric sessions in the critical care conference in Chhattisgarh, one in Raipur and in Bilaspur, and we were interacting with our ONG obstetrician friends. For some strange reason, there has been more presentation of these AFLP cases now in the community. They just walk in with bad liver functions. By the time you decide stabilize and planning delivery, this patient just fulminantly go into hepatic failure and dying off. So this is something that I just wanted to share with from my experience. And HELP syndrome we have already discussed. One of the criteria is mostly it is associated with severe preeclampsia. If you do a blood smear, there will be microangiopathic hemolysis with the blood cells. This we have already discussed, and just draw your attention to this homozygous deficiency of this particular enzyme, which is actually responsible for causing this AFLP manifestations. If there is a heterozygous gene, so gene screening may not be actually just heterozygous gene is not risky. But if you have a homozygous presence of this gene, then this is the one which is high risk. And challenges are there in terms of all these patients who have got multi-organ dysfunctions, challenges in there in administration of anesthesia for delivery purposes, because you need to have at least, if you're planning a neuraxial block, the platelet count need to be at least more than 80,000, for cesarean section more than 50,000, and high risk content must be obtained for all these cases, because the only chance we have to save the mother is to do the delivery of the baby without documentations, because otherwise there are chances of medical legal issues are very high in such cases. So management, as you manage any other sick patients, ABC of resuscitations, termination of pregnancy, with encompassing this anesthetic challenges, multidisciplinary team approach from the very beginning and counseling by the obstetricians, by the pediatricians and anesthetists with the involvement, close involvement of the critical care team is paramount importance. You cannot manage these patients, stabilize and just shift to a nearest referral center. And what about liver transplant in patients who face or land up in acute liver failure? Literature, if you see, very, very scarce data, because this King's College criteria, all the score, etc., which have been done, they have not been validated in pregnant populations. They have been developed long back, and none of them, see, all major studies for that matter actually exclude pregnant patients. So whatever the established therapy we talk about in non-pregnant populations cannot be applied to this pregnant population. Having said that, only is the paracetamol-induced acute liver failure, which is probably not an obstetric cause per se. They are the ones who can be extrapolated and be applied this King's College criteria for liver transplant. AFLP cases, when you have the facility or the infrastructures, they also can be considered for liver transplants. One of the series which actually almost looked at 1900 liver transplants, only 0.5% of the cases had pregnant ladies had liver transplant. But again, the graft survival or the functioning at the end of 1 year, 2 year success is not so good. HELP, 0.5% of all the HELP cases which are mentioned, data is available, have probably been considered for liver transplant. Again, success rate is not so good for such cases. Prepare for delivery, I think more or less we have discussed about it. Along with the mother, also think about the baby. If it is 24 weeks of pregnancy, plan for the lung maturity, have a neonatologist involved, and all other general organ support therapy should be provided. What about extracorporeal therapy? I think we had one of the sessions just before in the afternoon. Heme absorption therapy, as you normally contemplate for any other forms of acute liver failure, can be considered. That is, this Mars Plex can be considered. It's not difficult because you can use the same CRT machine with a specific unique filter which is there, and it is said to absorb the inflammatory cytokines or this liver-related toxins could be absorbed. But again, evidence is not high in its support, because again, pregnant populations are scarcely in literature. Some of the unique etiologies not to forget, because most of the literature that we study are from the Western countries. We have sickle cell, we have tropical fevers. This just need to be managed conservatively in the timely manner and to be referred to a higher center for better management. Most of them do very well with 90% of the survivals and good outcomes. So summarizing, I would say history and clinical examinations are the way forward. First, whenever you receive a patient, these are the things which will clinch you 90% of the diagnosis. Stick to basis in cases of resuscitations, because I strongly believe, be it life or clinical science, common things are common and uncommon things are uncommon. By doing small little things at the right time, actually, you can save more lives than not. Termination of pregnancy as appropriate with a quick assessment is important, is going to do the wonders. Mixed and overlap diagnosis would be there. At that point of emergency, you did not pinpoint ABCD, what is the diagnosis. Just manage the patients and at the same time parallelly keep on working on the investigating. Early referral to the nearest center and taking help of tele-ICU in today's era's time I think is going to be extremely helpful. With that, I conclude my talk, and I am happy to invite you for this obstetric critical care workshop, which is going to be held in the Criticare 2026 at Chennai. And this is the ICC Manual of Obstetric Critical Care. And there is also a 6 months obstetric care fellowship course, which National ICC is running. And twice a year, there is enrollment for that same. Thank you very much for your patient listening. Any comments or questions, welcome.
Thank you, madam, for sharing your valuable clinical insights. We now open floor for brief discussion, question and answers.
Thank you.
My question is regarding pulmonary embolism. I think this question can be taken by both Kapil or Dubey sir. The thing is, in the immediate postpartum period, if there is a scenario where there is a massive pulmonary embolism, as there was a case in sir's presentation, and given that all the modalities are possible, no financial restraint or something like that. So, what would be your modality? Systemic thrombolysis or catheter guided thrombolysis or probably percutaneous embolectomy?
Given a scenario, we will prefer to go ahead with catheter-directed thrombectomy because if you look at the possibility of bleeding tendencies, it will be at the lowest risk. And catheter-directed thrombolysis, even though dose is less, we are doing at our center thrombectomies, and we have a good results doing that. So we will prefer doing, but for that we require specialized center and the team and interventional radiologist has to be there.
I think, in fact, he has organized a meeting, Kapil has organized a meeting, and I was there. So catheter-directed thrombolysis, where you just use the TPA, and the dose is going to be just 14 to 15 milligrams, and the risk of bleeding is less than 1 to 2%. So that becomes a very good option. And second option is definitely going to be catheter-directed thrombectomies. Now, only issue is going to be require an expertise. We require those gadgets and the cost. Cost is definitely, it goes in 8 to 12 lakhs rupees, so that's not a simple cost.
At my center, it will be around 1.5.
Yeah, but that's just putting a catheter and thrombolizing with the TPA. So that's a cheaper one.
Actually, I think penumbra device, whatever is being used for that embolectomy, is available even in maybe district places, in many of the places.
Yes.
Even in our place like Kolhapur, we do have it.
Yeah.
Probably we should take more benefit of that in such scenarios.
Thank you all participants for those thought-provoking questions. And I would ask, so now I request Dr. Ashish Gandhi to felicitate our speakers and chairperson. Thank you. So we conclude this session. It's clear that obstetric critical care continues to evolve as a crucial subspecialty and which demand multiple collaboration with multiple teams.
Thank you everyone for the successful completion of day one of the conference. Just a general announcement. Tonight we have our gala dinner for all the faculty and delegates in the same hall. We have Central India's one of the biggest band. Please request everyone to be present and enjoy the evening 8 p.m. onwards in the same hall. Tomorrow morning we'll start again sharp at 9 a.m. So request everyone to please be present in the same hall at 9 a.m. tomorrow morning. Thank you.